All right, so we're going to talk now about the care that we give in each stage of labor. In the first stage, this is from beginning of labor through full dilation. We're going to focus on part of the care is going to be monitoring. We've talked about that part already, the assessment monitoring, and our goal is just to catch problems before they become severe. But also, we're going to be providing basic nursing care, okay? In regard to hygiene, we need to be giving really frequent perineal hygiene or the opportunity for the patient to do that, because even before the membranes rupture, there's a lot of mucus, a lot of blood, so it can get pretty uncomfortable. So we want to provide frequent perineal hygiene and change linens and pads as needed in labor. Some women will ask for some assistance with grooming in labor, like hair, makeup, things like that. In early labor or in the first stage of labor, a warm bath or shower can help quite a bit with comfort. So it can help decrease the perception of pain. Food and fluids. Food and fluids are controversial in labor. There are different opinions and there are different policies at different facilities. So when birth first came to the hospital and doctors began attending births in the early 20th century, they began to use a combination of medications, morphine and scopolamine, usually sometimes Demerol and scopolamine, that sedated the mother and caused amnesia, so that a lot of women, they called it twilight sleep, and a lot of women would go in, start getting their shots, and then they would not be aware later of what happened during that labor. At the time, they would use that type of analgesia through the first stage of labor, and in the second stage would use some form of general anesthetic. Early general anesthetics were given by inhalation, and anesthesia was not deep enough to require intubation and artificial ventilation. So there was the risk of vomiting and aspiration. The reason we have preoperative patients now in PO is because even though there's an anesthetist managing the airway, they're usually going to be intubated and ventilated during general anesthesia, there's still a risk of vomiting and aspiration. So for a long time, women in labor were instructed not to eat or drink anything once labor began, in case they had to have a C-section and had general anesthetic. That has kind of held on, even though almost all C-sections now are done with regional anesthesia. Very rarely is a C-section required so emergently that it requires general. It does happen. Oh, I won't say very rarely, I would say rarely. It does happen, but it's a pretty small percentage of births. And so the Cochrane Collaboration is a group that reviews research studies. And so they collected all the research studies they could find on eating and drinking in labor, and they didn't find any evidence that restricting food and fluids in labor in low-risk women actually improved outcomes. So keeping people in labor in PO is not necessarily evidence-based. However, a lot of facilities still do it. A lot of facilities have really different policies. At one place, someone might be able to eat light foods. At another place, they might be in PO except ice chips. Clear liquids is becoming more common, kind of in the middle. Usually those policies are determined by the anesthesia department, or at least anesthesia has a strong voice in those policies. However, labor is really, really hard physical work and uses a lot of calories and energy. And so sometimes someone who's in labor for a long time and is NPO or has decreased intake is not getting adequate calories and fluids, and that can actually slow down labor because their energy needs are not being met. Currently, ACOG recommends moderate clear liquids. Okay, if food and fluids are allowed, as a nurse, I would recommend light foods, because anything heavy, spicy, acidic is more likely to come back up, cause vomiting. IV fluids are usually given in labor to maintain hydration. If the patient is eating, sometimes IV fluids are not given. Elimination, you should know that a distended bladder impedes descent. If the bladder is distended, it makes it more difficult for the fetus to move downward. So it can slow labor. It also is more painful because the pressure on that full bladder. And one thing to keep in the back of your head, if your patient has an epidural, they've had really good pain relief, they don't feel a whole lot, and they begin having pain with contractions, make sure their bladder is being emptied, because sometimes they can have that breakthrough pain because of bladder distension. Also, if the bladder gets distended in labor and stays that way, that can lead to decreased bladder tone and uterine atony postpartum. So we really want to make sure their bladder is being emptied regularly. We want to encourage voiding every 2 hours. If they have an epidural or a spinal, they may not be able to void, and so an in and out catheter might need to be placed, or a Foley. If a Foley catheter is placed, make sure that that's removed during pushing, because we don't want them to push the valve out and damage the urethra. The presenting part may impede catheterization. So if they need to be catheterized, sometimes if they can't void in late labor, it's because the presenting part is squishing the urethra. And so it can be difficult to pass that catheter in because the presenting part may get in the way. In labor, first of all, in pre-labor and early labor, diarrhea is common, but later in labor, intestinal peristalsis usually slows down. So most women don't have a bowel movement during the active first stage labor. Sometimes if they've been constipated, they may at that point, but typically they've kind of had some diarrhea earlier and then everything has slowed down. Mobility and positioning. Walking can improve descent. It helps the fetus descend better, and it can increase the frequency, duration, and strength of contractions. So we encourage walking in early labor. If they're ambulating in active labor, we need to keep a really close eye on them and watch for progress, because we don't want an accidental delivery and fetus to be injured. Ambulation. In some facilities, ambulation is not allowed after rupture of membranes. There's a concern about the risk of cord prolapse or the risk of infection. I don't know if those are evidence-based policies. I know that they're the case in some facilities and not in others, but it's very common to not be allowed to move around after rupture of membranes. In bed, we can still help that patient that can't get out of bed to change positions in bed. We can help them move from a lateral to a semi-recumbent position and switch sides with lateral. If they are semi-recumbent, and that's going to be supine but raised up a little bit, remember we want to get them off the vena cava, so use a wedge or a folded blanket to tilt them to the left bit. You should put a folded blanket under the right hip, and that usually does it. Sometimes being upright in the bed, there are upright positions in the bed, and there are squat bars that allow a patient to take an upright position. Sometimes that can help with descent. Sometimes being on the hands and knees can help with back labor or with rotating a posterior baby. We can also help patients in a supported squat. An individual can help them maintain a squatting position. Being in a chair or in a rocking chair may provide a position change while still resting. Birthing balls, basically it's a big yoga ball. So someone sitting on a birthing ball, it can provide some comfort. It can help with descent by moving the pelvis around. It allows for freer motion of the pelvis than sitting in a bed. General supportive care in labor, we want to give emotional support. Labor is hard for many women, and so we want to provide that support that they can get through it. We also want to provide support for the partner or the family member or whoever's with them as their support person. That person may need breaks and may be afraid to go take them. They may need to get something to eat. Lately, the support person has not been allowed to leave the room in a lot of facilities. So making sure that they have the opportunity for meal breaks and rest breaks is good. We often get asked for advice and information. Remember that it is our role to give information more than advice. We may help with non-pharmacologic comfort measures and pain relief measures. And also the nurse would be administering pain meds at times. We also would be the one facilitating getting the anesthetist there to place the epidural. There is a role called doula that you need to be familiar with. I don't see them a lot in this part of the country, but I actually have friends who work as doulas. So you need to know what a doula can and cannot do and what the role is. A doula is a support person through the labor process. Now, they may be paid or unpaid, but most of the time, if we use the term doula, that's going to be a paid support person. And it is their job to help the patient advocate for themselves and help them to be as comfortable as possible and to help them achieve the birth that they want as much as possible. So a doula can maybe encourage the patient to change positions, can ask the patient what is it they're wanting in a particular situation. They can provide some non-pharmacologic help with pain, like massage, distraction, breathing exercises, things like that. They cannot give medical advice. They cannot assist with the birth itself. A doula is not the same as a midwife. Children at birth. So there's controversy about whether older siblings should be allowed to witness a birth. There hasn't actually been shown to be any harm to older kids from watching a birth. So if someone wants to have their children observe that birth, you can be reassured that that doesn't seem to be harmful. There are some things that need to happen though. First of all, well, for one, you need to check with hospital policy. But first of all, you need to make sure that the children who are going to be witnessing birth have been prepared. Do they know what to expect? They know that the person in labor may appear to be in a lot of pain, may be loud, may be distracted, may be grumpy. Do they know what they're going to see? Do they know that they're probably going to see blood and other body fluids? So have they been prepared for that? They also need a dedicated support person who is there just for the kids, who is not also the mother's support person. Okay. One person cannot meet the needs of the laboring patient and the needs of those children. So they need a separate dedicated support person, and they need to be able to leave if they're overwhelmed by what's going on. One last thing in regard to supportive care, if an emergency occurs, it's very easy for us to just begin hurriedly doing all the things that need to be done and forget that the patient in the bed is actually a human and has feelings and is terrified. So someone needs to be explaining quickly and calmly what's going on to that patient and the family. Okay, the next thing I'm going to talk about is nursing care in the second stage of labor.